Hi, everyone. Good afternoon. I'll wait just about one more minute as people filter into the room, and then we'll get started. Okay. Hi everyone, welcome. Thank you for joining us today. For anybody who doesn't know me, I'm Dr. Jessalyn Haladinsky. I'm a faculty member in the Center for Health Informatics, and I'm also an assistant professor in the Department of Emergency Medicine. Before I get started today, I'd like to acknowledge that the University of Calgary, located in the heart of Southern Alberta, both acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which includes the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. The City of Calgary is also home to the Métis Nation within Alberta, including Nose Hill Métis District 5 and Elbow Métis District 6. Now, it is my pleasure to introduce our speaker today, who's Dr. Andrew McRae, who's both a friend and colleague of mine. Andrew is an associate professor in the departments of emergency medicine and community health sciences here at the University of Calgary. And he's also a member of the O'Brien Institute for Public Health and the Leuven Cardiovascular Institute. Andrew completed his MD at Dalhousie and then his PhD in epidemiology at Western University. His research sits at the intersection of cardiovascular emergency medicine and health services, focusing on the diagnosis and management of cardiac presentations to the emergency department. And this work translates directly into clinical decision support. He's an investigator on a multi-center implementation trial of the Canadian Syncope Risk Score and is currently leading a nationwide prospective derivation study for a novel risk prediction tool targeting ED patients with acute coronary syndrome. He brings to his work not only deep clinical and epidemiological expertise, but a rigorous lens on how tools get built, evaluated, and actually adopted in practice. And I'm excited to hear a little bit about that today. So please join me in welcoming Andrew.
All right. Thank you very much for the invitation. It's a pleasure to be able to talk with all of you today. It looks like an impressive and accomplished group of people in the audience. So I'm looking forward to a really robust discussion at the end of the session. Dr. Holodinsky already did a land acknowledgement, and doing a land acknowledgement kind of let me reflect on the expression about doing things in a good way. And it's an expression that a lot of First Nations use. And it can mean a lot of different things, but one aspect of doing things in a good way that I saw that really resonated with me is learning from patterns in the past to understand current realities. And I'm going to be talking today about learning from successes and missteps in developing clinical decision support so that as we move into the AI era, we can be maximally useful to clinicians and patients. I'm going to start by talking about my positionality. This image is meant to illustrate my imposter syndrome giving this talk. I'm pretty comfortable skiing double black runs, skiing in the backcountry, but backflips are beyond my skill set. And doing this talk is the intellectual equivalent of a backflip for me. It pushes the limits of my skill set because my main disclosure, or perhaps a confession, is that I'm not an expert in AI or machine learning. I'm a clinician and a researcher. Most of what I do is to develop the evidence base to help guide emergency physicians diagnose heart disease faster and more accurately. So I've done a lot of work in cardiac biomarkers and risk prediction tools, and AI is really transforming this space. So I'm in the position of being a middle-aged dog who's trying to learn new tricks. And my goal for today is to have a dialogue with all of you about a few things that have been on my mind as I've seen some missteps in providing clinical decision support, both with traditional regression-based risk prediction tools and with new AI-based tools. And I want to talk about ways that we as researchers and developers can best create AI-based decision support tools that really do consider the granular decisions that clinicians make on in their day-to-day practice. The presentation includes a lot of content from a concepts paper that Dr. Holodinsky and I are shopping around to journals. So a lot of this intellectual property is shared with her, and I thank her for her input as well. So for anyone who's not familiar with the term clinical decision support systems are tools that synthesize patients' clinical data to give providers patient-specific information to guide better clinical decision-making at the bedside. There are a bunch that clinicians can use on their own personal devices, or it can be more sophisticated and integrated into an electronic medical record like this one that automatically populates elements of a cardiovascular risk score that I'll talk about in a little while. At their simplest, they rely on clinicians to input patient data, but the more advanced ones actually pull data directly from healthcare records to populate the decision support tools. And at the cutting edge, there's ambient AI that uses camera, sound, and sensor data to monitor things like movement and respiratory patterns, vital signs, and other clinical inputs that predict and alert clinicians for potential patient deterioration. In terms of workflow, AI-based tools can have touch points throughout the whole clinical encounter. And so they can comb through patient records, like I said, to populate commonly used risk scores or decision tools. Or if you build a machine learning algorithm into a hospital's IT system, they can estimate patients' risk of adverse outcomes and continually update probability models as patients pass through their journey in the hospital to generate even more accurate and patient-specific decision support. And finally, when we're talking with patients at the bedside, decision support tools also can include a generative AI component that can create patient-facing decision aids that can help patients and physicians make the best shared decisions by giving patients understandable materials that can help them understand their unique clinical scenarios and the unique clinical decisions facing them. So that's the promise of AI in supporting clinical practice. And the reality is, though, that we're just not there yet. In 2023, a scoping review examined the status of AI-based clinical decision supports in emergency medicine, and it described an exponential growth in publications over time. But out of the 650 or 700 AI clinical decision support tools described in the literature in 2023, most of them were still in the development or pre-implementation phase, and less than 5% were actually fully implemented and sustained use. So there's exponential development, but not exponential adoption. And there's a lot of good reasons for this. A lot of these algorithms or models haven't been validated outside of the population in which they were trained, which is an essential step in development and deployment. And in terms of infrastructure, most hospitals and EMR systems just don't have the computing power and resources to implement AI-based clinical decision support. And while some physicians are early adopters, even when an AI tool has been validated and deployed, there's still a lot of skepticism or lack of trust amongst clinicians that limits the uptake of AI-based tools into clinical practice. One key component of achieving clinician trust that a lot of AI-based clinical decision support tools might miss out on is that they don't address the actual clinical questions that clinicians and patients have. In other words, they're not fit for purpose. And that's not a new problem. It's true for a lot of traditional points-based risk scores too. But in creating clinical decision support tools, developers might not have thought out the granular cognitive steps that doctors use in reaching clinical decisions. And if AI-based clinical decision support doesn't map onto the discrete cognitive tasks that clinicians use in their day-to-day practice, then it can't and it shouldn't be used to support those processes or inform decisions at the point of care. Touching more on this concept of fitness for purpose, it's a problem with traditional regression-based risk models too. They sometimes seek to answer questions that clinicians don't really face in actual practice. They might be developed in the wrong population, and on the user end, we clinicians sometimes engage in mission creep, using the tools to try to answer questions that they weren't meant to answer in the first place. So one key argument that I want to make is that as potential developers, We need to ensure that AI-based clinical decision support needs to be fit for purpose. It has to address the exact granular questions that clinicians face on a daily basis. And based on that argument, I'm going to propose some development principles for AI-based decision support that can be applied across clinical domains. I'm going to use the example of symptomatic coronary disease in the emergency department as a worked example because this is my intellectual home turf. And so in the emergency department, we often talk about trying to diagnose acute coronary syndromes. That's an umbrella term that includes three conditions that have the same underlying pathophysiology, namely the narrowing and ultimately the blockage of the coronary arteries that supply blood and oxygen to the heart muscle. An occlusion MI, or what's often referred to as an ST segment elevation myocardial infarction, because it causes an elevation of a line on an ECG known as the ST segment. It's this little horizontal red line that you see down here in the ECG. That results from a complete blockage of a coronary artery, and it has a substantial risk of death or long-term cardiac disability. And outcomes are substantially improved by rapidly reopening that artery, either with fibrinolytic drugs, commonly known as clot busters, or with an emergency angioplasty procedure. And our goal in the emergency department is to identify these cases within minutes that the patient arrives at the door and to have them treated within 30 to 90 minutes of arriving in the emergency department. Non-occlusion MIs or non-ST segment elevation MIs don't have the ECG findings that indicate a complete coronary artery occlusion. Instead, we diagnose these with blood tests that show heart muscle damage. They also do better the earlier that they're treated, but they're not as time sensitive as a complete acute coronary occlusion. And then finally, there's a condition called unstable angina, which is a warning sign of a myocardial infarction that could happen in the near future. It has all the same symptoms as a heart attack, but the symptoms don't last very long. There's often no changes on your blood test results, and we don't always see the ECG changes, especially if the patient's symptoms have resolved by the time they arrive at the hospital. But these patients do need further investigations to identify any heart disease that needs treatment. The hard part is actually distinguishing these patients from patients who have other causes of chest discomfort. And we sometimes miss cases because symptoms can be subtle and they don't always follow the textbook. On the other hand, we also overcall a lot of cases of unstable angina and make false positive diagnoses in the emergency department, leading to hospital admissions and inpatient testing. Because coronary disease does carry a substantial risk of bad outcomes, it's part of our culture in emergency medicine that coronary disease is a can't miss diagnosis. And even if we recognize intellectually that there's no such thing as perfection, and there's modeling studies that show that testing any patient with less than a 2% probability of coronary disease can actually cause more harm than good, our existing clinical practice guidelines tell us that we should be striving for a miss rate less than 1%. If you survey emergency physicians, we talk about an acceptable miss rate somewhere closer in the neighborhood of 0.5%. And if you ask an American malpractice lawyer, the acceptable miss rate for a heart attack is 0. So caution has really shaped the way that we approach patients with possible coronary disease, and our culture is just to be very cautious when assessing patients who may have symptomatic coronary disease, and we err on the side of over-testing rather than under-testing a lot of patients. Before any risk prediction tools were developed, physicians, we used our gut to estimate the probability that a patient had symptomatic coronary disease, and collectively, our gut isn't all that bad, but predictably we err on the side of overcalling heart disease. One study done in the UK asked emergency physicians to rate the probability of a myocardial infarction in their patients using a 5-point Likert scale, including responses of this patient definitely, probably, possibly, probably not, or definitely does not have a heart attack. And just on gut alone, the area under the curve for diagnosing a heart attack, just based on physician's gut, area under the curve was about 0.76. And the sensitivity of saying somebody definitely or probably didn't have a heart attack was 95%. So not bad at actually ruling out heart attacks just based on gut impressions and talking to a patient. But not surprisingly, we overcalled things with the specificity of our clinical gestalt being less than 20%. So definitely overcalling the probability of having a heart attack. Fortunately, though, we do have more objective tests for identifying symptomatic coronary disease. Like I mentioned, we have explicit ECG criteria to identify patients who are eligible for immediate therapy with fibrinolytics or angioplasty, and we have blood tests to identify heart muscle injury. The older generation of blood tests that we used before about 2012 took a long time to identify heart muscle injury, but for the last dozen years or so, the latest generation of tests provided much more definitive results very quickly, often within 3 hours of symptom onset. But in the late 1990s and early 2000s, because the previous generation of blood tests were not sensitive enough to diagnose small MIs, scientists developed risk prediction tools to estimate patients' probability of having an acute coronary syndrome of any kind, whether it was an MI or unstable angina, with the goal being to reduce the probability of missing adverse cardiac events in the emergency department. This is one example. It's called the HEART score. It's probably the most widely used clinical risk score for symptomatic coronary disease in the emergency department. Like I said, it was developed to identify any acute coronary syndrome, including a heart attack or MI on the initial emergency department visit. And it was meant to be applied in any patient who walked through the emergency department doors with chest pain or symptoms of possible coronary disease. Um, the major methodological criticism for the HEART score is that it was literally developed on the back of a napkin rather than using formal statistical methods. But in spite of that, it doesn't perform too badly. The average AUC in subsequent validation studies for identifying patients with an acute coronary syndrome is in the neighborhood of 0.87. So it's not too bad. But since scores like HEART were developed, there really have been some sea changes in how we assess and treat patients with coronary disease in the emergency department. The ECG criteria that we use for identifying patients who need emergent coronary angiograms and having their coronary arteries reopened have evolved. And the newest generation of troponin assays that we use to diagnose heart muscle damage are really, really good at identifying patients with myocardial injury. So the likelihood of missing a heart attack with the current generation of blood tests is really, really small. And so we've got to this point now in 2026 where we don't really ask as a kind of a binary question, does this patient have an acute coronary syndrome? As I'll show in a minute, instead of asking a binary question, we ask a series of discrete granular questions in a very specific sequence. And each of those questions entail different time-sensitive diagnostic and therapeutic actions. And so that means that in 2026, existing risk scores like the HEART score I just showed are no longer fit for purpose. I think I might have just switched the wrong slide. There we go. Yeah. So the fact that existing risk scores might not be fit for purpose needs to be highlighted because there have been a lot of AI algorithms developed that emulate existing risk scores like HEART with the intention of identifying all cases of acute coronary syndromes among patients who present to the emergency department with chest pain. And I think it's a misstep to seek to answer the same questions as existing cardiac risk scores because I'd argue that they're no longer fit for purpose in 2026. You can develop AI-based risk tools or AI-based tools that perform really, really well for identifying acute coronary syndromes. This study, for example, sought to identify any patient with an acute coronary syndrome, including a myocardial infarction or heart attack, in patients arriving to the emergency department. They used ensemble learning methods and gradient boosting to develop a tool that had an area under the curve of 0.93. So the tool did a great job, but I'd argue that, especially in 2026, this tool simply does a better job than existing risk scores at answering a question that expert clinicians don't actually ask in real life. In actual practice, we undertake a series of discrete granular decisions, each of which entails specific time-sensitive diagnostic and therapeutic actions. First, when a patient comes in the door, within 10 minutes, they're supposed to get an ECG done. And we ask, does this patient have ECG findings that show an acute coronary occlusion? That's the first most time-sensitive decision that we make. If they have ECG findings of an acute coronary occlusion, we undertake steps to make sure that they get immediate reperfusion therapy within 30 to 90 minutes of the time that they arrive in the emergency department. If they don't have any ECG findings of an acute coronary occlusion, we can take a deep breath. We take a second and consider, okay, what's the probability of an acute coronary syndrome here? Is it so low that we don't need to do any further testing at all? And sometimes it's possible to say, no, I don't need to go down the road of testing this patient for an acute coronary syndrome because their probability is so low that I just don't need to consider that any further. But most of the time, if somebody has a reassuring ECG, we go on to do troponin testing to identify patients with non-occlusion MIs who need admission and timely treatment. For those that have reassuring ECGs and reassuring troponin concentrations, we then have to consider if there's another cause for their symptoms that need treatment, because there's a lot of different organs in the chest and the upper abdomen, all of which, or many of which, can cause symptoms that are similar to patients having heart-related symptoms. So there are other things that we need to consider that could need emergent treatment that we need to identify. And then finally, if we don't have any objective evidence of a heart attack or any other serious condition, we need to consider just what is the probability that they have coronary artery disease at all, because patients who do have symptomatic coronary disease obviously benefit from identification and treatment. So at least with respect to diagnosing acute coronary syndromes in the emergency department, we don't engage in a single binary decision, but rather a series of discrete decisions. And that insight has led us to create some development principles for AI-based clinical decision support that I think are generalizable across clinical domains. And so here are the development principles that we're proposing that the developers and clinician scientists should take into account when they're seeking to develop AI-based clinical decision support. And so first, like I talked about, step one is really think carefully about what exactly are the distinct clinical decisions that clinicians face, so that you're actually ensuring that the tools that you're developing are fit for purpose. And then once you've identified those distinct clinical decisions, you can then think about, do you need to use separate AI models to support each clinical decision? And then what actually is the best algorithm for each task? Because different clinical decisions might be best addressed with different types of AI algorithms. We should be developing and validating algorithms according to best practices. We need to think about human factors and how is this actually going to get used at the bedside, and ensure that the AI algorithms that we developed are able to continuously adapt to emerging evidence to optimize performance. So, like I suggested before, the very first and most important step is to identify exactly what are the distinct clinical decisions that we're trying to support. We might say we want to support the diagnosis of acute coronary syndromes, but like I just illustrated, that's not a monolithic binary decision. Rather, it's a series of decisions undertaken on a progressively smaller group of patients. We can help identify each decision node by actually breaking down the key actions that are entailed by those decisions. So, for example, sending a patient emergently to the cath lab for emergency angiography based on their ECG findings, or admitting them to the hospital based on their troponin concentrations. So, identifying each of the actual clinical actions that we take can be helpful in identifying the key granular clinical decisions that we might need to support. We need to consider what inputs are required to guide each clinical decision, and we have to consider when these decisions are made during a patient's trajectory to ensure that we have all the necessary inputs or variables available and provide the decision support at the right time. For example, it doesn't help to provide AI-based ECG interpretation 3 hours after the ECG is done if we're targeting a 30 to 90 minute treatment window. So talking about when we're going to integrate that decision support into our workflow is also entailed in large degree by what are the actual clinical decisions that we're undertaking and when. Next, we need to consider whether each decision needs its own model. Sometimes no decision support is required, or some decisions may be able to be collapsed based on expert clinical input. And these considerations help us decide on the inputs required, the timing of providing decision support, and the model type. Obviously, more models means more complexity, more resources, and more work. But sometimes, if there are a series of decisions that are sufficiently different and entail different actions, then different models are obviously going to be required. Once we figure out where an AI algorithm might be brought to bear on a specific clinical decision, we need to choose the best algorithm for each cognitive task. And some algorithms are better suited for different tasks. So obviously things like ECG interpretation or image interpretation, deep learning techniques are probably the best approach. If we're looking at developing tools for interpreting blood tests, we might want to choose something like a rules-based type systems like decision trees, or another approach like gradient boosting that might include not just the blood test values, but some other patient characteristics to improve accuracy. And then finally, for things like risk prediction, old-fashioned regression is still pretty good, but there are some other approaches like gradient boosting or random forests that we'll talk about explainability in a little bit, but there may be some performance gains there in using these approaches. And so having a careful think about which algorithm type is best suited for each task is an important consideration. Once you decide on the type of model, there's some key methodological considerations. So being clear about the clinical decision that we're trying to support is essential for knowing what to use as a reference standard or ground truth. So for example, if we're developing a deep learning algorithm to identify ECG findings of an acute coronary occlusion, the reference standard should be whether the patient has any findings of an acute coronary occlusion on angiography, autopsy, or clinical follow-up. If we're developing a machine learning algorithm to estimate the probability that a patient with reassuring test results in the emergency department might or might not have coronary disease, the reference standard should be whether there's any objective evidence of new or progressive coronary disease, or whether any treatments for coronary disease were instituted on clinical follow-up. So thinking through the choice of reference standards carefully once we have a plan to develop a model. We need to ensure the reliability of the data that we're using for model development. And then there's equity and validity issues that go along with ensuring the patients whose data is used for model development are actually representative of those that we would eventually be using the model to help. We need to make sure that training and validation data sets have sufficient numbers of individuals with the relevant known, unknown, and sometimes underappreciated risk factors for specific conditions to ensure that the model can be applicable to all potential patients that it might be used to try to help. Next, we have human factors related to usability and implementation. How is this best implemented into clinical workflow? Should it be something in the electronic medical record? Do people prefer to use it on their own personal devices? Is it possible to pull inputs directly from the EMR, or do clinicians have to manually enter data, which can be a barrier to use for some people? At what point in the patient's trajectory does the decision support get deployed? And what should the output be? Should it be a binary output? Should it be probabilities? It all kinds depends on the type of decisions that we're trying to support. And finally, we need to consider how to adapt to changes in disease epidemiology or patient populations, or the development of new diagnostic tools or therapies. And so to mitigate the risk of model drift, we have to plan for continuous updating and for learning of the model while it's in use and continuous monitoring of accuracy. So based on these principles, I think we can develop a framework for what a comprehensive clinical decision support suite for patients with suspected coronary disease might look like. We've broken down the distinct clinical decisions that clinicians make when they assess a patient with a possible heart attack. And each of these decisions is sufficiently different in terms of the actions they entail and the inputs that they require that a different model type is probably required to support each individual decision. And some model types are better suited for some questions than others. There's some factors to consider in terms of the output type, like the decision whether a patient needs to go emergently to the cath lab is a fairly binary decision, as is the interpretation of troponin concentrations to either rule in or rule out a heart attack. But for estimating the risk of coronary disease in patients with reassuring ECG and blood test results, some physicians like probabilities, whereas others like a more binary or categorical advice like yes or no, the patient should be referred for an outpatient stress test. So lots of considerations as we go through each of the granular decisions that clinicians face on a day-to-day basis that really inform our thinking about the model types that we should use and when they should be deployed, what inputs are required, and what outputs should look like. There's already many AI-based clinical decision support systems that address each of these individual decisions, but they're mostly standalone algorithms. I don't know of any comprehensive decision support platform that provides decision support from the time a patient arrives in the emergency department through the end of their emergency department encounter. So I think there's an opportunity to think about how each algorithm might work in a sequential platform. And one thing to take into account is that at each step, you're going to be asking questions in a progressively smaller group of patients. So models need to be trained in the group of patients that's left at the end of each step. And second, there's also a possibility of using Bayesian probability updating at each step. And so the post-test probability one step might actually inform the pre-test probability of a subsequent step as the probability of symptomatic coronary disease gets progressively smaller and smaller and smaller as you work down this tree of decisions that clinicians face. As we're getting close to the end, though, I want to have a conversation with all of you about the concept of interpretability or explainability, or the degree to which an AI tool's outputs can be explained in human terms, either post hoc or by some intrinsic interpretability. We can talk about the safety or regulatory compliance reasons that a tool should be interpretable to make sure that it's making safe recommendations. And experts talk about explainability being essential for clinician uptake and acceptance. I wanted to share a conversation that I had with a colleague who's a journal editor who knows a thing or two about data governance and management. They were providing some feedback on the manuscript version of this talk that Dr. Holodinsky and I currently have shopping around at journals. His comment was, as a clinician, I don't think I actually care how the model arrives at its output, so long as it's right all the time. Clinicians use risk prediction tools or base clinical decisions on the results of clinical trials, but for the most part, clinicians can't explain how a logistic regression model works or what a two-sample t-test does. So most clinicians probably don't really care about the inner workings of an AI algorithm so long as the output is right. So I wonder if explainability means something subtly different for clinicians than it does for data scientists. For data scientists, it probably means the model's inner workings. How did it arrive at the conclusions? Did it arrive at the conclusions in a sensible way? Whereas for a clinician, it's probably about what inputs led to the model's outputs. And I'll use a couple of examples. This ECG is from a patient who's having an occlusion MI. As occlusion MIs go, if there's any clinicians in the audience, it's on the subtle side. A novice clinician might actually miss some of the ECG findings that this patient is having an occlusion MI. But as a clinician, if I'm going to have confidence in a tool that tells me that this patient is having an occlusion MI and they need to emergently go to the cath lab to get an emergency angioplasty, I want to have confidence in the reasoning that the tool uses. I want it to tell me that if you look down here at the bottom in lead 3 in AVF, the T waves, or this squiggly line here, is of a bigger amplitude than the QRS complex, which is this little narrow sequence of lines here. That's a phenomenon called hyperacute T waves that we often see early in an occlusion MI. I want it to tell me that it sees a very subtle elevation in what's called the ST segment, which is this little line here that I'm pointing to. I hope you can all see my pointer. But I want it to tell me that it detects a subtle elevation in the ST segment here and here. And I want it to tell me that these T waves in here in AVR and AVL and V2 are upside down and they're not supposed to be. And so I want it to know that the deep learning algorithm is using the same reasoning that I would use when I'm interpreting an ECG so that I can be confident in its result. The second example is a chat that I had with ChatGPT in preparation for this talk. I'll preface this by saying that large language models are the wrong tool for clinical risk estimation, so please don't do this at home or at the bedside. But I gave it a description of a hypothetical patient and asked it to estimate the risk of any major adverse cardiac events in the next 30 days. And it gave me an answer that, as an expert in the field, I assessed to be correct. It supported that decision based on some of the inputs that I gave, and then I asked it to support its estimation with primary source evidence, and it referenced papers that I know to be accurate and reasonable support for these risk estimates, and they were not hallucinations. So most clinicians can't explain the inner workings of a large language model, and they probably don't realize that they're designed largely to put words together in a way that makes sense rather than provide risk estimates. But if I were a clinician using this, I might be reassured at the robustness of these outputs. Maybe it's just because ChatGPT probably gets asked this question a lot, so it's had a lot of practice doing this. But if I were a clinician using this tool, I might actually be reassured, probably falsely reassured, that the support for this output is reasonable, even if I can't explain how a large language model works. So does explainability mean something different for developers and clinicians, or should we be using a different term for what the clinician is looking for, something like justifiability or reassurance? Because I think both concepts are important for both the development and the uptake of AI-based decision support. And so I'd love to talk more about this in the Q&A period that we have coming up. I'm going to close with this shamelessly AI-generated summary slide. So as developers, to develop tools that are fit for purpose, we need to engage with expert clinicians to understand their exact needs in terms of the questions that we're trying to address with AI-based decision support. We need to understand the actions that each decision entails and the type of inputs and outputs that are required. And a decision support tool should be evaluated not just on accuracy, but also on usability, and should be able to integrate new evidence to ensure that it provides the right information at the right time in the right format. I have a few more examples of how these design principles might be brought to bear on other clinical decisions that we can talk about in the Q&A period. But I'm really curious to get people's thoughts, both as from clinicians in the audience, as well as from data scientists in the audience, about how we can best meet the needs of care providers and patients as we develop and integrate AI-based clinical decision support into our practice. So I think I'm going to stop sharing my screen here and give people a time to stop talking and give people some time to provide their input, because I'm curious to hear what you have to say. Thanks.
Thank you so much, Andrew, for that really informative, interesting talk. If anybody on the Zoom audience has questions, I would encourage you, you can either use the Q&A function or you can, use the raise hand function and chat. I see that there's already a question in the Q&A from Rob, so I'm going to read that out, but please keep thinking of other questions you might have. So Rob, relating to explainability and clinical use from a clinical decision support and regulatory perspective, at what point does a tool move from guidance to a medical device? And would there be a specific trigger point there? So great question.
That is a great question. I don't have an answer. And I think it's a question you should ask Health Canada, but you might not want the answer that they might give. So it's interesting because a lot of some of these AI-based clinical decision support tools have been created by private companies or companies that are spin-offs from academic institutions, startups from academic institutions. And so obviously they're looking to sell their product to clinicians and to healthcare institutions. And so yeah, at some point it probably, they do need to be thought of as medical devices. But then again, a lot of institutions are developing their own AI-based algorithms for either clinical decision support or to guide operational decisions. Thinking back to the talk that Mohammed Mamdani gave at the AI symposium that was put on a few months ago about a lot of things that are being done internally at his hospital in Toronto, where you know one thing he didn't talk about was the degree of oversight there. And so I don't know if there's a specific trigger. That's a fantastic regulatory question. It would be great to hear some thoughtful input from other folks. But yeah, there probably does cross. I'm not sure if the line gets crossed when you're able to download something from the App Store or sooner.
Encourage any other questions to either use the raise hand. Oh, perfect. Elliot, go ahead.
Thanks. This was a great talk. Very helpful, I think, especially considering, how many models we make that may not have as big a use case as we want in practice. Do you think there may be like a good use of making a new class of papers where clinicians describe like where they would like interventions or where soliciting sort of from the data science community and the machine learning people, like where they actually want us to make models and do things like this. And you could kind of decouple them from the modeling itself. If you have papers like this, then a lot of people then can try to, solve these problems individually.
Yeah, I think that's a great idea. So I mean the paper that Dr. Holodinsky and I are working on does that for symptomatic coronary disease, and I can I'm not sure if we need to, could you do it as a series of papers, or should it also be a part of when you're developing an AI algorithm, first engage with clinician experts and say this is where say have a publish a paper on the consultation process, and here's what we arrived at in terms of the needs of here's what we arrived at in terms of the clinical questions that we've defined, the clinical actions that each question entails, the inputs that are required, and the output desired. So having that as a you could do it as part of your methods paper, but also it might actually stand alone on its own and serve as guidance for other people who might be doing something similar. So I can think of examples of how we might do that for deciding which patients with symptoms of a stroke get transferred to the hospital, or to go to which hospital, for example. So if somebody in a rural center or in a rural environment has an acute stroke, there's an AI, or has symptoms of an acute stroke, the paramedics who pick them up, they have an AI algorithm. Are their symptoms consistent with an acute stroke? Yes or no? If yes, how long have they been having their symptoms? Because the duration of their symptoms dictates the type of treatments that they might be eligible for. And so if they're within a specific time window where they might be candidates for a particular therapy that's delivered at a tertiary or specialty center, they prioritize emergent transfer to that specialty center and bypassing the smaller hospital, for example. And so having experts to actually kind of lay out that particular all those particular pathways would be really helpful as an essential step for any AI algorithm. But yeah, having like a clearinghouse of questions that might be brought to bear would be useful. But I think if you're actually thinking of kind of a holistic, here's what a patient's journey might look like from the time they start having symptoms to the point where they get to hospital and through their hospital journey. Yeah, I'm not sure what the best approach is, but I think as a general principle, if you're looking to develop an AI algorithm to address a clinical question, engage in the process of getting expert clinical input, and publish that.
And I'll add one statement to that before we go to our next question, is that any opportunity you can get as a data scientist or a modeler to actually spend some time with a clinician in a clinical space, I think is really, really valuable. As I've been working with Andrew for quite a while now, I've spent a lot of time actually in the emergency department with Andrew as he's seeing patients, and to see the process of like how he thinks and where the decision points are and where the data comes from has been so valuable to me. So if you ever get that opportunity, I would highly recommend taking it. Okay, I see Ankita, go ahead.
Hi, Andrew. Very nice talk. So yeah, just a heads up, like I'm a bioinformatician with no experience in this clinical domain. So I see AI framework, which is solely based on the clinical findings, and there is no basically genetic information integration in those clinical findings. And in this framework, I can see towards the end, there is a probability plus risk tier group where a lot of uncertainty lies, like because we are finding the probability of CAD. Do you think that if we integrate, because that's the most confusing group, do you think if we integrate the genetic information, it will improve the model? Or it has like a lot of limitations? We don't have the valid genetic markers or the cost involved and everything, or it can be doable with the minimal cost involved, but it will significantly improve the model accuracy?
Yeah, I think it depends on the question and the inputs required to answer that question. And so if you're trying to make a decision, if you're making a decision whether a patient needs to have an emergency intervention to open up their coronary artery right away, really the only inputs that guide that decision are what's on their ECG. So I think that particular decision requires a very constrained set of inputs. If you're looking for does this patient have blood test findings that indicate a heart attack, you basically need the results of 2 or 3 blood tests. You need the troponin that indicates heart muscle damage, and you may also consider some other aspects like their kidney function, maybe a few other blood tests that may improve discrimination and their sex. But then when you're getting into prognostication, like what is the likelihood of this patient having symptomatic coronary disease? You can integrate things like family history that could be a proxy for genetics. if there are some genetic markers that have been validated to improve discrimination of prognostication of coronary disease, that might be a candidate input that an AI model might consider, or that a regression model might consider, that may end up or may not end up being useful, whether it's genetic markers or other biomarkers like their lipid profile and that kind of thing. So I think it's a bit of an empirical question what factors will go into improving discrimination for risk prediction.
Thank you. Yeah.
I see a question in the chat from Kathy. So should most decision support tools be built to address a series of questions? The example given is, readmission risk, so discharge or not, and then to a level of care for follow-up. So should we be thinking more about this sequential decision making?
I think to the extent that a particular decision might actually, just to the extent that there might be differences in how you might do something, then for sure. So if there is a possibility of saying, okay, if there are varying degrees of level of care for follow-up, or time to follow up, then and certainly if you can show that those actually change patients' outcomes, then sure, that the decision to we often don't undertake just a binary decision, can this patient be discharged or not, but we then say, can this patient be discharged? Yes, they can. If they are discharged, what degree of follow-up intensity do they need, and when? And that's often based on our gut estimation of what their probability of disease is. And so if we can show that if there are gradations in disease probability that can be meaningfully used to tailor intensity of follow-up, then absolutely, yeah, I think obviously, but the more we can make decisions more and more granular, but they each have to be actionable in their own way. So long as that there's actually an actionable decision to make, then yeah, I think the more granular we can get, the better.
While people might be thinking about others, I'll take the moderator's prerogative to ask a question. So you ended off on interpretability and explainability, and you also said trust in that statement. And so maybe to think about trust a little bit, as a clinician of a number of years, you have learned to trust your gut when you think that somebody is, having one of the ACS conditions under that umbrella. And, you've learned to trust that gut through, repeated exposure and, feedback of whether you were right or wrong. But I might put back to say, maybe you don't fully understand how your gut instinct works, but you've learned to trust it over time. And can we apply that same idea to some of these models where, you might not understand the inner workings, but over time of proven accuracy, and could that be through silent trial, or could that be through parallel workflow, that you can learn it's something that's trustworthy?
Yeah. Is the short answer. Yeah, I think it'll probably end up being a generational thing. I think I think for physicians for future physicians who are still in grade school, but by the time they start practicing as physicians, where AI will be ubiquitous, I think that there's going to be there's going to be just I trust this technology because it's existed as long as I have. But I think to try to encourage people to adopt things, yes, there will eventually be okay, I see this test is accurate in practice over the course of, I'm trusting my gut after 2 decades of practicing emergency medicine. But if we want uptake of AI-based decision support tools to happen faster than on a 2 decade time frame, you're probably going to need to provide some degree of essentially the equivalent of showing your work. How does the model make decisions? What are the inputs that it used to arrive at the conclusion that it did? So that degree of trust is actually probably going to happen faster if you're able to explain it.
Can I poke the audience for any thoughts further on that idea of explainability, interpretability? Is anybody on the call working in the explainable AI space and wants to jump in? Kathy, go ahead.
We're working in this space, but we're going to be talking to physicians about and patients about their thoughts on what would help them feel more trustworthy or comfortable if a decision support tool was used for their care. So I think we will get very different answers between the patients and the physicians that we talk to. And even among them, as far as, like you said, some want the granular detail and some just want to know that it gives a very high probability. If not, it, like you said, it's right. I don't know how we can say it's exactly right, but we often deal with sort of that probability and likelihood. But I was just wondering, like, what would be the best questions, since we're embarking on this qualitative phase, to ask physicians about that and to engage that sense that it would be acceptable in their practice or that it would be used.
So I think the starting point would be what information do you need to know about an AI model and how it makes recommendations for you to trust its output. It might be an interesting reflective exercise to say, well, compare that to your own gut feeling. Do you know how your gut feeling works? But a physician will probably be able to say, I can tell you what inputs I use in my decision making. And so is it important that an AI model considers the same things that you do versus a completely, or if it used a completely different set of input or variables to arrive at its recommendation? Does that change your perspective on whether you would trust that model or not? Yeah.
And do your patients, are they aware of these tools supporting the work that you do, or is it just the front-facing conversations you have with them that they care about, not necessarily the information that came to you to help with that decision?
That would be a good question for patients, yeah.
No, I'm just wondering about your experience. Like, do patients know that they are that your work is being supported that way?
Yeah. I mean, we're not using, at least I'm personally not using any AI-based clinical decision support right now. So, I'm developing AI-based tools, and so once we go to an implementation type study, I think that's might be an interesting question to ask patients. But we'll keep that in mind for a subsequent CIHR grant.
Okay, thanks.
And maybe I will end it off with, a parallel to what Kathy said, which is, when you use the heart score in the emergency department, do you explain the heart score to patients?
I don't use the heart score because I don't think it's fit for purpose, but other clinical decision support tools, like if a patient with a concussion, when I tell them, you have a concussion, but I don't think you need a CT scan. I kind of summarize the output of what the Canadian CT head rule would tell us, for example. And so I know based on a patient having all the low risk characteristics of a Canadian CT head rule, their probability of a serious intracranial injury that needs emergency brain surgery or admission to the hospital is less than 1 in 10,000. So that's kind of what I tell them is that you have a concussion, but in patients like you, the risk of having a serious brain bleed that needs emergency surgery or admission to the hospital is less than 1 in 10,000. And so I don't think we need to do any additional tests. And most patients are definitely okay with that if they can avoid having to wait 3 more hours in the emergency department for a CT scan.
Okay, well, thank you so much, Andrew, for spending your time with us today, and thanks to everybody on the call for your thoughts and questions. If you are thinking about this again late at night and have more questions for us, you should all know where to find me if you can't find Andrew directly, but we would love to hear more from you if you have more ideas in the future. So thanks, everyone. Enjoy the rest of your afternoon.
Thanks, everybody.